I was doing techniques to people without understanding what the driving mechanisms behind their pain was. And I found that deeply unsettling.
As a student, you need a framework, you need something to work
Well,
with.
that's the key. It's not rocket science, right? But gee, it's not common. There's nothing more joyful, I reckon, to see someone's life turn around. And I can't think of a job that I would ever do or prefer to do than the job I do. I deeply love that privilege of working with people.
Peter, thank you so much for joining us today.
Pleasure.
Today, we're going to be exploring cognitive functional therapy, not just what it is, but how clinicians at all levels, from students right through to more senior clinicians, can start to embed these skills into their practice and apply them to real-world patient scenarios. This approach is something that's supported by a lot of evidence and has been really influential in my clinical practice. So I'm really looking forward to unpacking this with you.
Yeah, great.
But before we get into what CFT is, I thought it'd be great to have a quick look at where CFT came from, just to give a bit of context to the discussion. Peter, I wondered if you could perhaps just give us a brief overview of what was missing in traditional MSK care at the time that led you to develop CFT in the first place.
So I probably have to go back a few years to kind of look at where my journey began, which was I did my basic training in New Zealand, in the south of New Zealand, a long time ago. And I remember going through my training and going, there's literally no evidence for anything we do. I was regurgitating stuff from books and I was looking for evidence and I couldn't find anything. And I found that deeply unsettling. And then when I graduated, I just did all these workshops, like weekend workshops. I learned skills around manual therapy and, muscle balance, and like just swap myself as workshops. I was in clinic doing techniques to people without understanding what the driving mechanisms behind their pain was. And I found that deeply unsettling. And so I was like, I've got to change. I can't keep doing this as a job. I can't fundamentally work in an environment where I'm treating signs and symptoms that I don't understand. And so that took me to Australia, because at that time I couldn't do further. There was limited further education in New Zealand, and I couldn't do a PhD, etc. And I had I've got a questioning brain. I was really fortunate to go to Western Australia at a time where Bob Elvey, who most people probably don't know, who was an extraordinary man who kind of pioneered the whole understanding of upper limb brachial plexus pain. But he was also really open and worked in a pain clinic, and he was a clinician and an educator. And he was kind of on this wave of understanding in neuroscience and understanding the psychological impact that pain had on that had psychological factors had on pain, etc. And so I was kind of in this space where I was a young and questioning person who had a whole lot of technical skills, but not really any deep understanding of how to apply them, when to apply them, and what was going on in terms of people presenting with pain. And so that took me on this kind of research journey, which part of my research journey actually has been this really interesting journey of exploring all of my beliefs and realizing that most of the things that I've been taught and I believe just weren't based on evidence, which again, for many people is deeply unsettling. But for me, it was kind of the opposite to that. It was kind of like an opportunity to grow in a different way, I suppose. And I've been lucky to have a parallel journey of always working as a clinician and always working as a researcher. So I could go back to the clinic and I could spend time with patients and I could ask them questions and play with what I was doing. And they trusted me to go the journey with them most of the time, and then develop hypotheses that we could then test in the research environment, and then look at our data and go, this data doesn't support our hypothesis. What's going on? And so it's kind of like this to and fro process of realizing that our beliefs were driving, my beliefs were fundamentally driving this whole paradigm of what I thought was going on. But it wasn't based on evidence at all. It's just a belief. And so that's kind of been like the kind of evolution of CFT, was to go, actually, we kind of were looking at back pain. We took on back pain because it's a leading cause of disability. It's such a massive problem for society that we just have such poor evidence that we can help. And that challenged me, because I was working with people with back pain. I saw them get better. I didn't know why they got better. And so part of that was a reflection of like, what is it that's happening? What's changing to get that person better? And so, if you look at our research journey, we've gone down biomechanics. We've looked at neurophys, like pressure, like tissue sensitivity profiles. We looked at psych profiles. We've done clinical trials, and we've just constantly been able to refine, I suppose, our understanding and kind of crystallize what we think now is the kind of like key elements of good patient care and outcome. But that's not to say that that process won't continue, because we learn everything from everything we do. We keep updating, because that's the beauty of learning, is that it's never static. It's like a journey that you just keep going. And every patient I see, I learn from something new, because everyone has their own unique combination of factors that are specific and individual to them. So it's a really long kind of overview, but I hope it gives you a capture of my own personal journey, which has been my clinical journey and my research journey, and it's been influenced by so many people who I've collaborated with in psychology and biomechanics, and amazing researchers who I work with who've been brave enough to call out my bullshit, and like question me and knock me back and challenge me, and that's been so important for my growth and development, I think, as a researcher, clinician, as a person.
Yeah, and it must be so great, as you say, to have those two strands, the academic and the clinical, run in parallel, as you say, because I think
100%.
it's particularly looking through a student lens. When you get more experience, it's quite liberating, as you say, to be like, hey, there's no recipe book. I need to look at this person as an individual and find out what works. But as a student, you're looking for something. You're like, you need a framework. You need something to work with.
Well, that's the key. I think that's the key. Yeah. And I think that's the journey I've gone on, is to go, actually, we need a whole bunch of skills, and they're quite diverse skills. And that's what I think makes my job such a cool job, because actually I thought the key skills were my manual skills, and I spent literally hundreds of hours refining my manual skills. I can crack any joint in your body. I can teach it, but I hardly ever use it, because I realize it's such a limited tool for the people who I see. There's all these other skills that are so cool, that are so helpful, that I wish I'd been taught early on in my journey.
Yeah, absolutely. And so for those then who aren't familiar with cognitive functional therapy, CFT, if you were to give a brief sort of summary of what that is, how would you describe that to a student or a new grad or somebody that's not heard of it before?
So CFT, we kind of really battle with, like, what do we call this thing that we do? And there's a strong cognitive component, and there's a strong functional behavioral component. And anyone who understands CBT will see that there are aspects of CBT in there as well, because what we now know about pain, particularly persistent pain and persistent back pain, for example, a person's thoughts, their emotional responses, and their behavioral responses become part of a network that sets them up for ongoing pain and sensitivity. So let's take an example of a young lady I saw late last week. She developed pain as a 13-year-old. And back pain. She got taken to a chiropractor who said, "Scan, you've got a scoliosis. This is the cause of your pain." She then went on a journey for 14 years of being repetitively treated by the chiropractor for her scoliosis, and being told, this is your posture, and this is this, and this is this. And then she became frightened, because there's something, and she'd been told she had hypermobility. So all of a sudden you got a young woman who is lost confidence in her body. She thinks it's out of alignment, and she feels vulnerable, and she becomes frightened to move. So all of a sudden you've got a belief, that's a cognition. You've got an emotion, which is fear and worry and distress. And you've got a behavior as, I need to protect my body, and I need to guard it, and I need to avoid stuff that might put me at harm. And and then these kind of internal body responses around over tensing and perceptions of your body, that then sets her up for this ongoing loop where it self-feeds, where those thoughts and emotions and behaviors set her up. She comes to see me at the age of 27 going, I've just got this ongoing pain and distress, and I don't know what to do. And I can't do my job, and I can't sleep, and I'm not engaging in physical activity. And I'm thinking, am I ever going to have kids? And this massive impact that should never have happened at the age of 13, that has this long tail and trajectory. How does CFT work with that? It goes, what are the key elements around this person's pain experience? So, we need to screen for serious pathology, but we explore the person's beliefs and their social environment and their emotional responses to pain and their behavioral responses to pain. We watch how they move and how they behave, and she's holding herself tense and breath holding and guarded, and she's frightened. Then we go, the key pillars are kind of three key things. Number one is education around helping them make sense of what's going on. She didn't know. She came in going, I believe I've got scoliosis and hypermobility and I need to protect my body. She walked out with the belief that she's holding all this tension in her body because she's frightened. But actually, when she relaxes and moves, it gives her pain relief. And so there's the reconceptualization part, which is the cognitive part. The behavioral part is taking her back to say, hey, it's safe for you to bend and to lift and to relax and to move normally and to get back to the stuff you love. That's called the exposure bit. That's taking people back to feared, painful, and avoided activities and movements based on their things they love to do. And the third bit is the lifestyle bit, which is she's doing no physical activity. She's not getting enough sleep. So just educating her around getting her back to doing stuff she loves. So what are the things you love to do? I love to swim and I love to walk. Why aren't you doing that? Well, I'm so exhausted when I come home because of this pain. I just want to lie down. It's like, okay, so if we could give you strategies to not have so much pain, how would you feel about that? It's like, yeah, I think I'd do that. So let's work out something that you would love to do, not what I want you to do. What do you want to do that you can just build into your life, and then start giving her some relaxation techniques before she goes to sleep so she can get more sleep. And all of a sudden you disrupt this whole process. So the C, the F, and the T are these kind of three pillars of the making sense, the getting back, building confidence back in the body to do stuff you love, and coaching healthy lifestyle behaviors are the three key elements. It's not rocket science, right? But it's not common.
Yeah.
And it can powerfully change people's lives.
Absolutely. And I think that there's a couple of things. I mean, firstly, I think the biopsychosocial model is something that's been around for a long time and even longer than we think it has. I mean, when I registered to work in New Zealand, we had to write an essay on the Maori health model. The Maori health model was already, discussing all the interplay of these things, but it's so easy to talk about it and to say we're working a biopsychosocial model. But that example you've given is such a great way of embedding it. You know what I mean? It's one thing to ask about, how are you managing mentally, what's going on socially. Exactly. But as you say, it's addressing it. And I think the other thing that really comes out there is, as you say, and we do see this with patients, is sometimes it is that common sense. There's patients that are like, I've been told I've got to sit bolt upright.
Yeah, and it's really uncomfortable.
And what if you don't? Like, well, it feels better, but that's not good for my back. And it's
exactly, and I feel guilty, and I'm being told off. And another great example. So she was working in a shop where she's having to lift heavy boxes, and her back would go into spasm. I'm like, how do you lift a heavy box? Well, she squats with a straight back bracing her core. So I said, let's do a little experiment. Like, how heavy are you happy to lift? She's like, oh, maybe 10 kilograms. I've got her to lift 10 kilograms, like 5 times. And she's going, yeah, that's bringing on my pain. Let's do it completely differently. Let's not get you to squat. Let's just get you to bend over and round your back and not brace your core, and let's see what happens. She goes, oh my God, that's so much easier. But isn't that dangerous? I'm like, actually, there is no evidence in the literature to say that's dangerous. You're like, surely that's not true.
But and it shows, as you say, those beliefs, those expectations, those cultural factors, or whatever, is all feeding into that. And so massively. I suppose the other thing on that then, which was obviously part of the reason for having this discussion with you, is what do you feel is missing then in current education? What do you feel we could do better at undergraduate level to help embed some of these skills for students and new grads?
Look, I've had these discussions all the time, and I reckon it's a bit like I've had to clean out my cupboard. It's a bit like going into my garden shed and going, I've got stuff there 30 years ago. I can't stick more stuff in my shed, right? I've got to get the old shit out and make sure I keep the good bits and get rid of the other bits. Because what we keep hearing is like, our programs are completely full. We can't add anything else in. And this is just another burden on students. And I'm like, I can remember being taught stuff, and I know all around the world people are taught stuff is not really that important. Like, there are key things that are really important. And I reckon that's about cleaning out the cupboard and going, what are the really important things that we need to upskill students for and clinicians for, that provide them skills for learning for life, but also provide them with the skills to adequately deal with the enormous burden of chronic disease that we have in our society. So they are communication skills, fundamentally number one. And like, if someone had told me that at the beginning of my career, I would have gone, oh yeah, that's crazy. I want to learn how to click the back. It's like, like they are critical, because communication skills, you don't get to hear someone's story if they don't trust you. They won't tell you things that are important if they don't trust you. They won't come back if they don't trust you. You will get sued if they don't like you. Like, there are so many things that protect you around communication. That's such a critical skill. But they're all, sensitively exploring, a range of factors so that we do, we have to make sure we're safe. So we have to be able to screen out for serious pathology and pathology where we need to redirect those people, or we need to manage them differently, frighten the people, the majority of the people who don't have pathology, who are just left, in our rotating doors of healthcare, just appallingly treated, actually, and provide those key skills around, basic interview examination skills around teaching stuff that matters. Like, I spent years doing passive movement, intervertebral movement testing. Well, we know that you and I can't agree on a level. We can't agree on what's stiff and what's not. Why are we teaching students stuff that we can't, even experts can't agree on? That just doesn't seem sensible to me. So, but, the ability to observe human behavior is really important skill. So just to observe how somebody moves, you can see that's a reflection on their levels of fear or confidence in their body. We do need hands-on skills, and I'm not against hands-on, because that is another powerful component of communication. Could be reassurance and facilitation and feedback, but I see hands-on as being much broader than I'm lying you down on the bed and treating you. And then health coaching is something that we should be embedding in, because it will run across all chronic disease around, just motivational techniques to get people to re-engage in healthy lifestyle behaviors. They're really important skills that will set up and underpinned by a really strong clinical reasoning framework that sets you up for life around learning, I reckon.
And I think, like you're saying, that those skills it's learning how to learn. It's learning how to develop.
Yeah, it
it's
is.
setting somebody up to develop, rather than saying, and I remember when I trained, subacromial impingement, this is what happens. This is your model. It looks nice and neat, and it feels...
until you meet a patient.
Exactly. And you're like, well, why is the scapular setting not working? Why is...
Exactly,
yeah. And there's something I heard you say as well on another podcast around, it's almost like we find a pathology and then pick a profession to right, you guys are going to treat this and you guys are treat it, without understanding what those patients really need, which I think is a really good way of conceptualizing that.
Yeah. Yeah, it's kind of flipping it around. And I think that's been a big part of my journey. Instead of saying, these are the skills I give to my patients, instead of saying, what are the skills our patients need us to have to care for them?
And I think as well, you've touched on something there, validation, understanding, and that's what I hear a lot from patients, from other clinicians, is that's so essential, just sometimes giving them the time to tell their story. And as you've said,
it's therapeutic in itself.
Exactly, yeah. And being prepared that patient may get upset during that consult.
Yeah.
And that's a normal part of that process.
That's therapeutic as well. That is therapeutic
Absolutely.
as well. Yeah, and I have, when we go, we train clinicians in this approach, and they often go, well, what do we do? I'm like, have you ever had a family member or your best friend cry on you? And I go, yeah. What did you do? You just listened. You went, that's okay. That sounds tough for you. Like, hey, that's normal. Like, pain has a massively disruptive effect on people's lives, all aspects of your life. It's completely normal that that's distressing. So I think we often spend a lot of time normalizing what people think is psychosocial factors. And it's like we put them in a psychosocial in this black box. It's human. It's being human. Like, tell me someone whose mood is always high. That is not human. Human is we fluctuate in our mood and our worries and our stresses and our sleep and our health behaviors. It's just being human. And like, if we reflect on that in our own lives, we'll be way more empathetic in other people's lives to just normalize it. Hey, that's normal.
I think that's such an important thing for new grad students to be aware of is that it's going to feel uncomfortable the first time that happens, but learning how to deal with that, how to respond to that is such an important skill with like you say, all patients.
Yeah, and also in ourself, because I think if we're not comfortable with someone else's emotions, good chances we're not comfortable with our own emotions. And so if we're not comfortable with our own emotions, we've got to really wonder where we should be working.
Yeah.
And if it's with highly distressed human beings, you're going to have a pretty tough job, I reckon.
Yeah. Yeah, it's that looking in as well as looking out and realizing where that's coming from. Absolutely. One question I have as well, and I remember this when I first, started working more in pain management, because I found that validation that when patients come in who'd had years of pain, sometimes months of pain, and really struggling, you let them tell a story. How do we start that process of moving forwards from there and not get stuck in that validation?
Yeah.
I remember
totally.
that being something that, people come and you listen, and sometimes you feel like, okay, we've had 3 sessions and
you're
we're
stuck
not
in the misery.
moving beyond this. Yeah, how can we start that process?
Yeah, so part of the way we work with CFT is around the interview. So, we collect the stories, really important, and we validate the person. So, that sounds so tough. That sounds like you've had a really hard journey. What would your life look like if you didn't have that problem? Like, how would your life be? Wow, I used to be this young woman's like, I used to loved swimming and I love running. I love going to the beach. And are you doing those things? No, I'm not. Would you like to do those things again? And they're like, yeah, that'd be amazing, but I don't think it's safe for me. So if we could build your confidence back, and let me examine you first to make sure it is safe. But if we could take you on a journey to get back to the things that you would love to do, how would that be? And you change the narrative, right? 'Cause I think if you're stuck in the misery, like my life is miserable, like not personally, but I have a very fortunate life. But if I'm stuck in the misery and I have no hope, then the misery continues, right? But if I've been told I've got this scoliosis, that's for life. I've got joint hypermobility, that's for life. I might not be able to have kids. That's a massive threat for me. If all of a sudden I have an understanding that actually those things are not going to define me. I can get back to the things I love. It is safe for me to have kids. Something switches in a person's brain that all of a sudden looks to the horizon and not looks to the path I've come on. And we're explicit around doing that. Like we never dwell in the past. We acknowledge the past, but we're always forward looking to go, what are your goals? What are the things that light you up? What are the things you love? What's stopping you do them? Because that's the essence of the journey, because it's always goal orientated. And, that might be learning. I had one guy in like 2 weeks ago and he was so down and his joy was to do Brazilian dancing, salsa, and he hadn't done it for 5 years. And he was just at home and he was eating crappy food and drinking alcohol and he never went out. He was socially isolated. And I'm like, why aren't you doing salsa? He's going, because my back and every time I do it, I flare up. I'm like, well, let's check you out. He's tense as hell. He's frightened to twist. Of course, you can't do salsa if you're frightened to twist. So I just took him through a whole exposure program, showed him it was safe to twist, got him to practice some salsa moves, and said, when's the next salsa class? He goes, tonight. I said, you have to go. He came back in a week, a completely different human being. He had been to salsa. He'd been out of the house. He started eating good food. He was planning for these other things in his journey. Now, I could have gone, oh man, you've had a shitty life. You've been stuck in your house. It sounds really hard. Let's talk about that, and not moved him on. But I found something that lit him up, and it was salsa. And I'm like, okay, what is it about salsa that you can't do? Let's check it out. So the examination was a salsa examination. The examination was tailored to his fears and to his goals, which is so much better. Like, I never lay him on the couch because I didn't need to. Because he didn't have a fear of lying on his couch. He spent 5 years lying on a couch. That we sort of set up our treatment rooms to go, oh, we interview you and lie on the, range of movement, lie on the couch. Why do you want to put a dude on the couch who spent 5 years lying on a couch feeling miserable when he wants to play salsa? It doesn't make any sense.
And that was one of the things I found so rewarding about working in pain is because these are people that have been struggling. You get to know the person. It's not just another shoulder that may well get better in 3 months. You're working on finding what makes this person tick. How can I find
100%.
an inroad that's going to get this person? And the other funny thing that I found with it is you could spend weeks and weeks educating, telling people stuff. But once you show them,
counts.
Once they come back to you and they tell you all the stuff that you would have told them anyway about pain. They say, you know what? I get pain
100%.
Sometimes. I'm not going to be pain-free, but I've realized I just have to get on with my life. And it's like
it doesn't matter
come to that
now.
conclusion themselves.
Exactly. Yeah, totally. And that's the beauty of behavioral learning is 100% agree with you, Alex. It's you do your own reflection. And, what do we say about learning is the things you learn the best are the things that you learn yourself. The things you're told are more likely the things you argue with. It's really hard to argue with your own experience, right?
Yeah. And would you say that that's a big tenet of CFT is really...
Massively.
I've heard you use the jigsaw puzzle analogy before. We're just giving the patient the pieces and helping them to make sense of that journey.
100%. And that's why we don't lecture people. So for my explanation to this guy was to say, hey, this is how I'm making sense of what's happened. And and often at the end of an examination, I'll go, what do you reckon's going on? Well, I reckon from what I've experienced today, I'm as stiff as a board and I've been frightened and I've stopped moving because I thought I was going to harm myself. I've just realized that actually moving makes me feel great and I'm going to change what I do. So they've done their own education like that. Beautiful. Sometimes you need to just frame it so it's really clear. But if they can do that work themselves, it's so much better.
Yeah, and I think you've hit on some great points. Obviously, communication, therapeutic relationship, massive validation, empathy. And also, I think for students and new grads that we want to come out and we get into Physi-ed because we want to help people, and we want to fix people.
Totally.
And it's that we think that we have to fix the problem. We have to do it for them. And in reality, a lot of the time, the patient, we're facilitators, really. We're guiding them along that journey.
Yeah. So I just on that, Alex, I kind of see myself way more as a coach than as a clinician, I think. I often use the example of, I love the outdoors and used to do a lot of mountaineering and stuff. But like if you're on rope with someone who's really frightened of heights, it's so important they have confidence in you. And you take little steps and you're on rope and you're checking in. And that's what we're doing with a lot of our patients is we've got them on rope. And it's like, I'm trustworthy. I've heard your story. I get where you're at. But it's your journey and I'm going to help you work your journey. I can't walk it for you. I can't carry you on that journey, but I can help facilitate you and nudge you and support you on that journey. And it takes so much pressure off you as a clinician because it's not on. I used to feel so burdened when I would do stuff to people and they come back the same. I was like, what? There must be something wrong with my techniques. I maybe have to go to another workshop. It's like, and there was this rotating door and it was like, I've got to change this thinking of mine that it's not about me anymore. It's about what I can do to partner with somebody.
Yeah, absolutely. And I remember something again I really struggled with is I think the pain education, and I'm thinking of obviously yourself, but people like Lauren Mosley, David Butler, and you hear these people talk and you're like, this makes so much sense. But then the patient comes through the door and it's having those skills to translate that knowledge into a session. And you've talked a lot about the communication, the goal setting, I think is really important. That's something that's very overlooked, I think, is what do you think's going on? What do you think you need?
Yeah.
From an objective perspective, then, where do you kind of start with those patients? How do you, prioritize what you're going to look at physically and then target because you've said obviously movement is influenced by fear, beliefs, behavior.
Yeah, massively.
How do you start that safe? If you're a new grad, where do you go with that initially?
Yeah, so it's a really good question. So that's where the interview is so important because that interview builds trust, right? So if you think about someone who's had lots of terrible healthcare experiences, they probably come in not trusting you for a start. So my first question to every person who walks in my door is, can you share your story with me? And they often go, like, where do I start? Like, wherever you like. And they will always tell you something really important within the first minute. It's my experience. Like, it started when I was 13. I've got a damaged back. I've got a disc bulge. I used to be this guy. I used to be this fit, healthy, active guy. And now I'm this broken, whatever. Like, they will tell you something so important about their story right at the get-go. And then it's kind of like that unraveling of like collecting information about, how's that for you? How does that impact on you? What are the things you can't do? What are the things you'd love to do? What are the most important things? So if we kind of rate them, if you wanted to get something back first, which would it be? And look, you can utilize the patient-specific functional questionnaires to help facilitate that. So I think it's quite good for students to go, what are the big things that are really fundamental barriers? Now, for one patient, it could be like recently, I can't sit. I can run, but I can't sit. And so I don't sit. So what does that stop me doing? I can't drive. I can't travel. I can't go out for dinner. I can't go to the movies. Massive. So you gotta examine sitting, right? The other guy I suggested was he wanted to do salsa. What is it you can't do? So let's check out what you do when you arch and twist and how do you do that? And he's like stiff and breath holding. It's tense as hell. It's like, okay, let's get you to relax and breathe and do it. It's like, oh, that feels better. And if it's too scary to do it there, do it lying down. Roll your knees from side to side and breathe and relax. And then go up standing and do it again. How's that feel? So it's always guided by the patient. The young lady, it's sitting at a desk. It's like, okay, try relaxing back and picking up a weight. Let's have a look at how you do that. So that's the F bit. The function bit is like, it means your examination is person-centered. We talk about person-centered care. Most examinations are so remote to the patient's needs and goals and concerns, it's not patient-centered. So in a sense, your interview builds trust, identifies the goals and the barriers to those goals. The examination, of course, screens for, pathology if it's important, like doing a neuro, if there's, signs of, radicular pain and loss of sensation. You're going to make sure, you're not dealing with pathology in that case. But for the majority of cases, it's very functional.
Yeah.
And very many of my patients, I never lie on the couch because it's just not indicated. And that then takes you on to you're basically road testing them for what you're going to give them.
Yeah. And I always remember hearing Chris Littlewood talk years ago and said about with shoulders, the most special orthopedic test. And it's the thing that the patient struggles with, make it relevant to them rather than blindly say, let's do these.
Yeah.
Eight special tests that I've learned. Yep. What are you struggling with? Let's look at that. Yeah. And then, like you say, it's modifying that. How can we change the way you're moving or your beliefs to try
how can we build confidence in you doing that? Yeah, 100%.
Yeah.
So shoulders, backs, necks, knees, hips, ankles, wrists, elbows, it's all the same.
Yeah. And I think the beauty of that is you see that improvement straight up. Is it the right thing? Well, they'll tell you, do it this, try it this way, try this, try that, the other.
Totally.
Now we've got something. Great. Let's work with that. It's not a case of go away, do these exercises.
They go, that person listened to me. He explored what was important to me and he addressed the things that I wanted to be addressed. And that's where we got to check in to go, can you tell me what you expect from today? What are your hopes for today? And if they're like, I think, there's a difference between what your goals are and what your expectations are.
Yes.
So they might have an expectation you lay them down and do ultrasound, but their goal is to play salsa. It's like, do you think like doing ultrasound lying down will help you play salsa? And they're like, probably not. So which is more important? Salsa. It's like, great. Can we explore something different today? And they're like, sure. Didn't expect that.
Absolutely. It's joining those dots and working with that. And I suppose then we've talked a lot about the people who are appropriate for CFT, obviously people who've struggled, people who have lots of pain. Who are the people that perhaps are less appropriate for CFT or certainly, need a different kind of approach? If you're a student and you're listed to all this, when do we not necessarily want to go down this route?
Okay. Cancer, infection, fracture, cauda equina, like the big serious stuff. refer on. Acute radiculopathy with progressive neurology. Like, don't just go, oh yeah, normalize your movement, off you go. If you're dealing with pathology, then you got to really be very sensitive to what's happening there and obviously refer on. The beauty is, like, the majority of the patients we see, unless you're working in an ED where the percentage of those patients are higher, the majority of people coming into primary care can be easily screened because we've got very clear guidelines around screening. And the other thing that I love about the approach is it protects you as a clinician, because if you do a behavioral experiment, for example, and I've think of patients recently who I've seen who you test them with functionally and you realize that as they start to relax and move, the pain ramps up. So then you're thinking, what's happening here? So the protective behavior is a good thing. If you got a fracture, it doesn't help to relax and move normally. It's bloody painful. So in a sense, the examination really protects you because you're never saying, you got to do this. You're going, how is it for you when you do this? So you're always checking in with the patient around if the pain's escalating or the distress is escalating. And that's really protective of us as clinicians. The answer to you is the majority of people that I see in clinical practice, the majority don't have pathology. I would say one in, I don't know, most of my people come in with a bucket loads of scans. So they have been thoroughly examined in the first place, right? The majority I see are absolutely amenable to this approach to management, which is the primary approach that I would use. Even in acute pain, if you think of most acute back pain, it's not from falling off a house, it's from picking up a shoe. It's like rolling out of bed, and you realize it's all of these loading biopsychosocial factors that set us up for a pain event. And the last thing we want to treat is someone with a pain exacerbation, like they've had a terrible injury. But often I think we miss that in a lot of acute pain as well, where it's actually a pain exacerbation of an underlying sensitized system.
Yeah.
So I would say there'd be very few people, unless you've got suspicion of serious and specific pathology. And specific pathology, I mean radiculopathy. We know almost all my patients have got, been told they've got disc bulges, annular tears, facet joint arthrosis, goodness knows what. That's not pathology. That's just more normal morphology that we've stuck a pathological label on, unfortunately, and that does so much harm. And that's probably our biggest uphill battle in health at the moment, is just demedicalizing all these crazy labels we stick on people because they've had an MRI scan and been told they're all worn out and broken when they're not.
Yeah, and I think that hammers home the importance, and this was something I always felt, is it took me a while to get to the point where I was, you could be really confident that you're not missing something. The importance of knowing your red flags, knowing your serious pathology, and
really
how to spot that, because without that, you're a bit lost at sea, because you're like, well, if I don't know what it's not, then how do I know what I can do? So it's so important that students, new grads, understand
and check back in
risk
every time that person comes in. That person's not improving. I'm like, why? The why question is what drives the research for me. It's what drives me as a clinician. It's like always hypothesis testing. We're always testing hypotheses in clinical practice. What do I think's going on here? What are the targets for the intervention? Let's target them and let's see what happens. If it's not changing, do I need to update what I'm thinking?
Absolutely, yeah. One other thing I wanted to ask you, and I'm aware there's not probably not an easy answer to this, but obviously around the world the role of physiotherapy is changing. In the UK, for example, we've got the first contact practitioner and MCAT roles. There's a lot of triage, and so you've got a 20-minute appointment where the goal is really to rule out the nasty stuff and point them in the direction of physio or whatever treatment, which may take 3, 6, 12 months sometimes to access. What do you feel, what would your advice be to those people? These are advanced clinicians working in senior roles who are very time poor, and care's quite fragmented. It's not easy to access a psychologist, a physio. What can we do, I suppose, with the time we've got? What would be the priorities of this approach for those people?
Yeah, so if you've got 20 minutes, I think you have to do some agenda setting right at the beginning for that patient. I think otherwise you're going to have a terrible life in your job. If they come in with an expectation that you're going to diagnose them, set them up with a treatment plan and take them on a treatment journey, you want to set that clear that that's not what they're going to get. Like, I would be agenda setting to say, hey, I've got 20 minutes. My job today is to make sure there's no serious pathology involved in your problem, and then point you to the most appropriate path for your journey or recovery. That's my job today. And you set the agenda right at the get-go, because otherwise you're going to have very upset and annoyed patients who are like, but what am I going to do? And you're going to have that'll be a very stressful job where if you don't set the agenda at the beginning. So if that is your job, then that's a really important job. And if that's the concern of the patient, so if the patient's coming in thinking I've got cancer or I've got, whatever they're thinking, you need to know that. What do you reckon's going on? I'd want to know that right at the get-go. What are your expectations today? Because I want to make sure that what I'm delivering is linked to that. Or telling you I can't meet those expectations today because this is what I'm here to do. I think that's so important. Like, we see GPs, and I don't know how it is in the UK, but in Australia, general practitioners work between 10 to 15 minutes, and that's what they do, right? And of course, the risk for them is they are just, to get people out the door, they have to give them a script for radiology or a referral or drugs, because they've got to get them out the door. And our toolkit is different, because our toolkit, if you're going to take it on a CFT journey, is building alliance and confidence and whatever. The other thing I would do is, I don't know if you've seen the Evolve Pain Care Academy website, but we have a portal for patients that has patient stories, infographics, videos. It's designed by patients for patients. There are portals out there. I'm sure you've got them in the NHS. I think I know that Chris Newton, Gurpreet Singh, and George McNamee have developed online portals for patient information in different languages that just help to educate patients around what's happening for them. I think that's really important. So you kind of nudge them towards a journey. It's not this is what's going on. I can't treat you today because that's not what this service is for. Here's a resource or a place you can access further information, or a couple of places, and I will refer you to a service that will help you manage your problem. Now, if that's a 12-month wait list, that's horrible, because that person's just left hanging for 12 months. That's what we're dealing with in the world at the moment. But I think if you carry the burden of having to do everything in that 20 minutes, you're going to burn out very quickly.
Yeah, I agree. And I know that's something I've heard you say before for students and new grads around the importance of sustainability. We know that the workforce is, a lot of people leave the profession because of that.
Massively.
But I think that's such a great point. And it comes back to your point again about communication, about that agenda setting, making it clear at the start.
Important.
Because the last thing you want is to get 15 minutes in and be like, right, we're done. And the patient be like, but that's
no, we're not.
not what I'm here for. Yeah. And how many times do you go to your doctor or whatever, and you perhaps want a bit of reassurance, you want a bit of education, and they're like, well, here, I'll take this. And it's like, well, I didn't come here for medication. I want I want you to tell me what's going on and what I could do.
And what it highlights to me, Alex, is, it's something we're quite interested as a group, actually, of showcasing what that might look like. And I don't think we've done a good enough job. I don't think we as a group have done good enough job, demonstrating how do you do that? That's actually it's a really skilled thing to take someone who's highly distressed and disabled, and they have an expectation, and to meet their expectations and make sure you safely assess them and frame that consultation in a way that they walk out going, gee, I was listened to, I was cared for, I was reassured, and I've been given a direction that gives me some hope. That would be super cool.
And one of the biggest challenges, again, comes down to time. And I know, again, I've heard you say before, psychologists, you don't just suddenly be like, right, you've qualified, crack on. And I think sometimes, like you say, you need to see it. You need to see somebody who knows what they're doing do it. Exactly. So you can be like, now it makes sense.
Yeah.
Because sometimes, people tell you and you're like, I understand. And then you've got this.
But I don't know what it looks like.
Exactly. Yeah. And and patients, if they're distressed, you're struggling to build that trust, that rapport.
Yeah.
Really useful.
Yeah.
Peter, I think you've shared some absolutely fantastic information with us here. Just a couple of things before we wrap up.
No worries.
If you're a student on placement, listening to this,
Yeah.
and you're going on placement again tomorrow, what would you say is, what can a student do tomorrow, or a new guy do tomorrow? What can they change straight away about
Listen,
their
listen
listen,
and watch.
listen, and what?
There are I have two senses that are operating all the time, my ears and my eyes. Like, I listen deeply and I'm watching like a hawk because it gives you so much information around the person, what's happening with them. It saves you so much time. So they are the two things that I would really encourage you to do. And, use touch effectively, kindly, gently, but don't put all your eggs in one basket. You'll be very disappointed. It's a powerful tool, but it's not the only tool. You need a broad skill set. But, people often go away from, say, workshops that I do and go, just have this open way of communication now. And I learn so much more so quickly. It's actually made my consultations so much more efficient. I can get to the heart of things. I think, unfortunately, we teach students to think in terms of boxes, but people's stories never linear. And it's the stories that we remember. And we have to fit the stories to understand we're covering all the different components. But be brave enough to ask someone, can you tell me your story? You'll be shocked to hear what you hear, and it will give you something and you'll remember it. I remember stories of patients from many years ago because it's a story, and that's how we've learnt for generations, is storytelling.
Yeah, absolutely. And I think that's something, again, that's really important for people to take home is it's easy to listen to this and think, well, I've already got to ask my past medical history, my history of presenting condition, all these other things and blah, blah. But actually, this is more time efficient. If you let that patient talk, they will often give you a lot of that information up front without you having to, and then you move and be like, look, I just need to ask some screening questions and we can,
exactly.
we can perhaps move on from there.
100%. Yeah.
So, and I think, again, just to go back to your journey again, something that's really stood out from hearing you talk is that thing of not just blindly, and I know this is really hard when especially if there's a lack of supervision, you're on your own, but be like, well, I was taught that this is this pathology and it needs this treatment. And so if it's not working, I must just need to do more of it or, keep going down the same path. It's about calling out and being like, hey, look, this isn't working. And there's something that's missing, and being confident enough to investigate that more.
Yeah. And I think it kind of circles back to some of those things we talked about earlier, is like, if you understand how a person ticks and if you understand what motivates them and the things they would love to do, if you put your focus on that, you're going to have a really happy patient. They're going to love you. And the other thing is, I always say this, is I get lots of gifts and cards and God knows what from happy people, and they never tell me about their pain score. They always tell me about something they've got back in their life. I never hear about their pain score. So we have to move away from pain scores to go, tell me about your life and tell me about the things you want to get back in your life. Because when you get stuff back, the pain scores don't matter so much.
Yeah. Yeah.
And they never tell me. They never go, oh, my pain's 3 out of 10. It's like, fantastic. They go, I climbed a mountain. I'm playing with my kids. I'm sousering. I'm, whatever it is. Like, that's the joy. And there's nothing more joyful, I reckon, for me as a clinician, to see someone's life turn around. Like, I had a chap in who had 2 spinal surgeries. He was thinking of a fusion, and I saw him last week, and he goes, I'm running. I've got back to running, and I had a holiday in Vietnam with my family. They were his 2 goals. It's like, I've done it. And it's like, that is so cool. I'm like, yeah, I still get a bit of pain, but I've got my life back. And like, that's the stuff that will keep our students I love my job, and I can't think of a job that I would ever do or prefer to do than the job I do. And the reason I still do clinical work is because I deeply love that privilege of working with people. And I'll keep doing it as long as, my marbles, stay cohesive and they don't walk me out the door and put me out to pasture. But it does make me sad when I hear people tell me that they don't see a future in our profession, because I think we have such an amazing profession, actually, but we don't have health systems that make it easy for us, I think.
Yeah, no, I agree. And it's so easy to get fixed on another knee, another back, another hip, another shoulder. But in reality, it's another person. And every person is different. Every person is unique. Yeah. And that's where the reward comes from of physiotherapy, is seeing that person.
Deeply rewarding. Yeah.
Yeah, fantastic. Peter, again, thank you so much for your time again today. I suppose
It's a
last one
pleasure.
thing I want to ask you is, obviously, that I'd like you to talk a little bit about the Evolve Pain, because I think there's some
Yeah.
great stuff on there, and,
Yeah. So,
for students, any other resources, any other things that you think would
yeah.
be useful if people want to
Yeah.
learn more about
So
this?
after the Restore trial was published in the Lancet, we were flooded with people saying, how do we access this? How do we learn about it? And we decided to set up a social enterprise, which is a non-profit. We self-funded it without our own time and resources. And we have so much free information on there, we got a free course, which we really designed for students. And we're going to put a case up because people have gone, we'd love to see what a real case would look like. So we're working on that as well. And that's, it's kind of, the whole platform has got a portal for patients, a portal for clinicians, and then tiered learning. So there's free resources that people can access, which will give them kind of like a scaffolding. There's all the key papers that we think are important. Some of them are not ours, but are just great papers that we think are important for understanding and supporting patients with pain. And then there is some tiered learning, which is paid access, but students get it at a 50% discount. We were all students once upon a time. And the other thing about the platform is that if it works, the people in high income countries will subsidize people to access this knowledge in low income countries. So in a sense, students get a half price, people in middle income countries access at half price, people in low income countries access it for 10% of the price. So part of our mission is not to share knowledge to the wealthy countries in the world, but to share knowledge equitably. And that's part of what we want to do, because we think knowledge should be accessible and widely shared. And we really value feedback as well. So people give us feedback. It's how we learn. So if it's not useful for students, tell us how it would be more useful. What would be more useful? Like, and we're working on other components that we've had feedback on around, skills for developing, understanding pathology. Clinical reasoning is a really key skill, probably one of the most important skills that often people struggle with. And we've got part of our scaffolding is around developing skills of clinical reasoning around cases, because I think case-based learning is a really useful way to learn.
Yeah.
Because you can start applying it in other cases. So that's the Evolve Pain Care Academy. We're really early. It's only 6 months that we've launched, and we're really busy building resources. We've had, I think, over 4,000 people now on the site accessing the learning stuff. So, and that's across 104 countries. So we've got limited resources, but we're beavering away in our spare time to kind of to do that, because we think it's important.
Yeah, no, absolutely, and I'll put links for all that in the description for this, and also for the Restore trial as well, because I think that's something
So the restoredbackpain.com is the other website that we developed. Yeah.
Brill, because I think that's something we've kind of touched on, but the evidence really supports this approach, doesn't it? I think the Restore, was it a 3-year follow-up you had with that as well? So it's showing that
Lancet
it's not
Rheumatology.
just it works now and then things go back 3 years down the track. You're still seeing those improvements with patients, which is so important.
Yeah,
really amazing.
Important.
Peter, thank you so much for your time. I really appreciate it.
Yeah, a pleasure. Love to chat. And any feedback from your listeners about the site, we'd love to hear from them.
Thank you.
Good on you.